Good afternoon, everyone, and welcome to today's webinar, Advancing EMS Data Integration in Michigan. It is such a pleasure to have all of you here. My name is Sharon Kim, and on behalf of the entire Michigan HIMSS chapter board, I'd like to thank all of you for joining us, and we're really excited to have you with us. This is the first webinar of our new 2026-27 Lunch and Learn series. These webinars are designed to bring together healthcare, technology, and public health leaders to share practical insights and highlight innovative work happening across Michigan and the nation. Our chapter is part of a larger global HIMSS network that is committed to advancing the collaborative use of information, technology, and policy to improve healthcare. Now, as a chapter, we do this by creating opportunities for education, collaboration, and networking among partners across the healthcare ecosystem. And today's webinar, I think, is a really great example of that mission in action. Of course, none of this work would be possible at all with our amazing chapter sponsors. So I did want to take a moment to recognize and sincerely thank them. Their ongoing support allows us to continue offering opportunities for our members and the broader healthcare community. And we, again, truly appreciate that partnership and commitment. Now, it is my absolute pleasure to introduce today our presenters. Samantha Ivan is the Director of Health Policy at the Center for Health and Research Transformation, or CHART. She leads health policy initiatives that support health system transformation across Michigan, including projects that are focused on emergency medical services, care coordination, and public health collaboration. Emily Bergquist is the Director of the Division of EMS and Systems of Care at the Michigan Department of Health and Human Services. Emily leads statewide efforts to strengthen Michigan's EMS system and advance emergency medical services through policy, systems development, and strategic partnerships. And finally, Ed Worthington is CEO of Advanced Health Technology Solutions, or AHTS. Ed has spent more than 2 decades developing health information technology solutions that improve data exchange and interoperability across the healthcare ecosystem. We are so incredibly fortunate to have all 3 of them with us today. But before we begin, I'd just like to mention that we are hoping to have a substantial Q&A session at the end of today's presentation. So please submit your questions at any time using the Q&A feature. My colleague Linda McMillan and I will be monitoring the Q&A. And if we aren't able to address all of them during the session, we will try to follow up afterward, get everyone the information, and of course, share our speakers' contact information at the end so you can follow up directly. Thank you again for joining us. And with that, Samantha, I will turn things over to you.
Thank you so much, Sharon. So you can advance the slide. All right, so why are we talking about EMS data and why now? As I'm sure most of the people on this call know, healthcare interoperability has been a big deal for a really long time, and there's been a ton of investment in this space, but EMS has been largely left out of those conversations. And there are a few reasons for this, like EMS is technically considered a transportation provider. EMS is, governed by the Department of Transportation at the federal level. But also, EMS's data is captured in a different standard than the rest of healthcare. That has presented challenges historically for EMS data integration. But I think the biggest reason is that people haven't understood the true value of this data source and the potential for us to better understand the communities that we are all surveying and the disparities that persist there. I think the true value of EMS data is in how we can help our communities. But there are also some really other great things to note, like EMS providers are frequently the first clinical touch point for most patients. EMS encounter data can support a wide range of needs, care coordination, public health surveillance, quality improvement. But as I mentioned, EMS data have been siloed. The good news is that Michigan is exploring practical, that's a key word here, approaches to make EMS data more actionable and shareable. And part of that is sharing data appropriately. Next slide, please. So for the webinar today, we've outlined 4 learning objectives. I'm going to read through them really quickly. 1, describe the role and value of EMS data integration in supporting care coordination, public health, and statewide interoperability. Number 2 is explain Michigan's emerging workflows for routing ADT notifications to EMS providers and converting EMS encounter data into ADT messages. The third is identify privacy and data governance considerations for EMS data sharing, including approaches for flagging and managing specially protected information. And then the fourth is recognize barriers, lessons learned, and practical opportunities to advance EMS connectivity across EMS, health systems, HIEs, and public health partners. Next slide, please. Here's the agenda for our session today. We have a lot to discuss, so thanks for bearing with me through my soapbox on the value of EMS data. Emily Bergquist is going to kick us off by discussing the state's priorities related to data sharing. Then I'll talk about how we're managing privacy and governance in EMS data sharing, specifically focusing on that SPI flagging and routing framework. And then Ed Worthington from AHTS will discuss the technical workflow he is using to convert EMS encounter data into an ADT format. And then we'll wrap up with barriers, lessons learned, opportunities, and a peek at what we're working on right now with our partners at MyHIN, the state's designated health information exchange. And with that, I will pass it off to Emily.
Good afternoon. It's 12:08, so it makes it afternoon. Everybody, thank you for having me. And I think before I get into my actual slides, while it's on this introductory slide, I'll just say most of the people in the attendee list I actually know from either my previous life or my current life. And why I get kind of nerdy and really passionate about this project is because I am a paramedic. I spent a long time on an ambulance, kind of on the other side of the street, so to speak, trying to figure out what was going on with my data. And the amount of work that the EMS clinicians do to put the information into the system is not small. So it's really positive to see this many people on this webinar today. So you can go to the next slide and we can talk about why I think this is so valuable. So EMS clinicians, the calls they go on, not only are they oftentimes the first encounter, they oftentimes are solo encounters. And I think that that is something that often gets lost in the discussions around, people want to talk about, this patient went to that hospital. There are oftentimes a lot of patients who are seen by EMS clinicians that don't go to the hospital. So there's a lot of folks who stand to learn more about their patient population by having access to this data, because these relationships that EMS clinicians are forming in communities gives a perspective that, primary care physicians, specialists, and hospitals can't really have access to without it, because they don't go into people's houses very often, if ever. So it's really beneficial to the hospitals to understand, this person's been seen 5 times for the same thing before they ended up in your department, or for a primary care physician to understand that their patient is, falling frequently or having difficulties managing their blood sugar, things like that, that they wouldn't otherwise see if they weren't connected into the encounters that kind of aren't going anywhere. My soapbox on this is the feedback on patient outcomes. I think there's nobody who goes into EMS and becomes a paramedic or an EMT without having some sort of benevolent feelings about doing good and creating positive outcomes in the universe. And right now, for most EMS clinicians, the only way to know what happens to your patient is either, one, somebody follows up, like a patient shows up with a tray of cookies or something like that, or for the clinician to kind of go into the hospital and be like, where'd my patient go? What's happening? Because there's no real feedback loop universally in the system. It's really important for them to understand, what's working and what isn't doing, or what isn't working. It's helpful for planning. It's helpful for surveillance. I see in our chat, we have a couple of our partners from public health here that use our data already at the statewide level for these particular pieces, it'd be really great to be able to expand it out to more folks that aren't necessarily I say the choir, we're preaching to the choir, but the choir is kind of in this audience right now. But by doing statewide integrations, we could, expand that out into the people who are not as in the know about the data. And then this rural and underserved piece kind of ties back into there have been communities where I have worked where there are not primary care clinician offices. And so EMS actually almost functions as an offshoot of primary care, specifically in rural communities, because people don't want to go somewhere else. They don't want to be somewhere else. This particular type of integration is especially helpful to them. So we can go to the next slide, and I'll go on to our next talk about what has been happening and what we are going to try to do. So our goal here is to try to connect our statewide EMS repository with MyHIN, which is the state's health information exchange, to enable the ability for everyone to have the privilege of the data sharing, as opposed to, what we've kind of been doing in a lot of areas is, one agency, one health system, or one agency with MyHIN. We're going to try to get the whole bucket all at once in order to get the outcomes to the providers, in order to feed quality improvement. A lot of folks don't realize that our office is actually in charge of every clinical thing that happens in EMS. It's very different than the rest of healthcare. Every clinical protocol that is out in the system has, been touched by this office on the idea that we're doing evidence-based work. If we don't have outcomes for what happens after the patients leave EMS, we're only seeing outcomes to hospitals, and that's not really the long-term part of the Plan, Do, Study, Act. We'd really like to be able to know, when we change from this medicine to this medicine, what happened to the patient's actual long-term outcomes. So it would be really fantastic for us to be able to create that piece to improve clinical outcomes for our patients. It would hopefully make it so it's more interoperable. So the goals that we have would be to kind of translate the data into a more usable format for the rest of the healthcare system. And then we want to be cautious and thoughtful about how we're doing it. So if we do it kind of once for everyone in this whole privacy, consent, and governance, we can kind of make sure it's covered for everyone, as opposed to the smaller agencies or the agencies with less resource trying to do it for themselves. And I'm talking really fast because we really want to let you ask questions at the end. Next slide, please. So for many of you who are here, and you have heard me, I'm going to use the word lament about this goal. This has been a goal for quite a few years now, and we've been running into, I just say, like one brick wall after one brick wall, and I've got, like, I don't know, a toothpick to take them down, but we've been working on it. So in Michigan, we are kind of an open state for who documents in what system. So we actually today have 15 different EPCR vendors in the state of Michigan, and each one of them, while we have a data standard, there's some visibility things that happen where we have some questions about, what was the question that the clinician was actually answered? Is that translating to, the national EMS information system the way that we think it is? We've seen a lot of variation, specifically into some deep work we've been doing with post-crash care. But how do we figure out how to, clean that up as much as we can? How do we make sure that the patients that we document in the clinical record for EMS are actually the same patient expressly with patients who have more common names or misspellings, or a patient who might be, unconscious at the time of the incident? How do we make sure that those things match up correctly? And then how do we make sure that it's happening in, I'm going to say, the most efficient way? From the operational side, I think everybody here knows that I work for the state government, and we don't exactly have the most amount of money. So a lot of things have been related to resources, where we get kind of a little bit into it and then realize it's going to be a larger project that we can afford, or we don't have enough human capacity to be able to do that particular work. We are currently working on an agreement with the Rural Health Transformation Program to be able to fund this work over the next couple of years. So we're really hopeful. I'm the most positive about it right at the moment that I have been. We have, at least for the next 5 years, if we can get like the hard work done, the maintenance will hopefully be a little bit simpler. I think this training and change management, this is the convincing folks that it's a good idea and also that it's valuable, which hopefully will then translate into people putting in, quality data to be able to be matched and then receiving quality data back. And then lastly, this is one I think most folks are familiar with, the rural pieces of like, how do we make sure that we're getting it in a timely fashion, connected the appropriate way without making it too much of a burden to folks. Those are our barriers. We can go to the next slide. So as I mentioned, the Rural Health Transformation Program, they wrote in for this integration into the actual application. So they're very committed to making this happen. We are hopefully going to be able to leverage the data repository we already have, because fundamentally there are a handful of agencies who have enough resources to be able to do this themselves. But when we have, I think today, 796 EMS agencies that put data into our system, I would hope that the MyHIN people can see the value in doing one connection as opposed to 796 separate connections, or same thing for the health systems, especially when they're receiving patients from a large urban or rural catchment area. Doing an integration between a given rural hospital and the 12 different EMS agencies that transport there is really more than anyone has been able to kind of tackle. The hope is by leveraging both our system where everyone participates and the MyHIN system where everyone participates, we'll be able to kind of cover everybody all in the same stroke. The gaps piece, the transport patterns and system needs, I kind of talked on this earlier. I'm also going to throw in here that like community paramedicine is in play here. We in Michigan collect data from several community paramedicine programs who are serving folks as almost like physician extenders. And I know that some of those folks are actually documenting multiple times. So they're documenting inside our system. They're documenting inside maybe a healthcare system. They're maybe sending messages to different healthcare providers. So the hope is that we can try to capture that all and address this gap to make sure that everybody has all of the information that they need. And then I think that the last bullet here is like the most obvious thing of all. I think that's why they wrote it into their application. When I talked to them when they were drafting the application, they were like, well, this is, kind of a slam dunk for the rural health transformation priorities, because it is connecting under-resourced and underserved communities to be able to make sure that the resources can kind of flow back to the communities in need. Next slide. And that is over to Sam. I wasn't clicking my slides at the same time. And so now it's back to Sam to talk about her pieces of making sure we follow all of the rules.
So much, Emily. I appreciate you giving that overview and describing what some of the state's priorities are, because I think it's really important to make sure that the work that we are doing is aligned with what's happening at the state level and within rural health transformation and other sources that are interested in investing in this type of work. So next slide, please. I'm going to talk a little bit about what we're doing to make sure that we're protecting sensitive data. So to make EMS data useful, stakeholders also need to make it appropriately shareable. And that really requires clear methods for identifying and managing sensitive information. EMS records, which I'm going to talk about throughout this section, may contain sensitive information across a number of categories, dozens of data fields, and not all data should be routed in the same way to all recipients or receivers. Instead, data sharing workflows have to account for state and federal privacy requirements, and they should also be taking into account ethical considerations as well. Next slide, please. So let's talk about SPI specifically, which is specially protected information. EMS encounter data can contain information that requires special handling before it is shared through downstream systems. Um, EMS documentation often includes rich narrative and situational context. It's one of the most important opportunities and challenges for EMS data integration. And sensitive information can appear in this narrative text. For example, a patient may discuss their substance use disorder history with the responding paramedic, who may document it in a free text narrative field. And this information needs to be protected. SPI may be subject to heightened privacy protections depending on the type of data and the use case. Again, for example, federal protections related to sharing substance use data is really a clear-cut example for this. But without a well-tested framework, organizations are at risk for oversharing, undersharing, or avoiding sharing altogether. And the goal of EMS data sharing should be practical, policy-informed routing of data to appropriate receivers. Next slide, please. So what do we mean in our framework when we say SPI? For the purposes of our EMS data sharing work, we've defined 5 categories of specially protected information, which are listed on this slide. And it's important to note that specific handling rules depend on applicable laws, policy, data use agreements, context, and other information that's not listed here could be considered sensitive or SPI if it's subject to heightened protections. Our SPI framework helps to identify potentially sensitive EMS data within these categories and route it appropriately based on the recipient, the purpose, and the governance rules. I want to talk also about a number of design principles that guided the development of this framework, which I think are immensely important when you're talking about how to appropriately share sensitive data. So we included principles about patient privacy and safety, minimum necessary data sharing. We made sure to emphasize practical implementation for EMS and HIE workflows, transparency and auditability, consistent handling across agencies and systems, avoiding unnecessary suppression of clinically useful information. So again, we developed this framework to not be overly sensitive in how it is flagging potential SPI, and then also support for scalable statewide implementation. Next slide, please. So this slide describes how our framework was developed, tested, and how we operationalized it. First, identifying where SPI may appear in a call record, and I think the next slide shows some of those data elements and categories more specifically. As I have mentioned a few times, there are many opportunities for SPI to show up in EMS data, and some of these data elements are structured and some are free text. And that means the logic that we're applying in this framework is also dependent on the data format, not just the data element itself. So it really requires a deep understanding of the data that you're working with. From there, we classify the type or sensitivity category and flag the record, depending on how the data should be routed. The HIE applies routing rules based on recipient and permitted use, transmitting, withholding, or masking information as appropriate. And maybe most importantly, we test, audit, and really work to refine the process to ensure that it's doing what it's supposed to do. Next slide, please. Yeah, so this is the slide that describes where SPI may appear in EMS data. This is not a comprehensive list, but I think especially for some of the EMS folks on the call, this will give you an idea of some of the pieces that we're putting in our SPI flagging framework puzzle. So here are some of the categories and data elements that may contain SPI. Next slide, please. And then as we're talking about data sharing, there really are a number of questions that need to be discussed and considered to make sure that the data are shared appropriately. Making the correct handling and routing decisions really depends on who is receiving the data and why they're receiving it. So these are a list, excuse me, an example list of some governance questions that really need to be considered when you're talking about data sharing for potentially sensitive information. And then next slide, please. Okay, finally, some lessons learned from the development of this SPI framework. We've found that developing this framework really required a nuanced understanding of not just the data source, EMS data, but also EMS workflows, EMS conventions, and other things that are really unique to the way that EMS operates and how it differs from healthcare operations and healthcare data norms, because there are a lot of really key differences. And without that nuanced understanding, you're not going to be able to create a framework that appropriately and accurately flags and routes data as it should be routed. And with that, I think the next slide is Ed.
Yep, thank you. I think we can go to the next slide. All right. So I think, with this project, right, in this pilot, we were kind of presented with, one major, I think you'd say, not major, one technical problem, right? EMS data typically comes out of a system in a specific format that nobody else uses outside of their industry. And when you're sharing data, especially through like a health information exchange, with a broad area, a broad group of people, some of whom you might not know who's going to be getting the data till it hits, an information exchange. The lowest barrier to entry for a data format, at least at this time, is, an HL7 message of some sort, typically an ADT, right? Any organization that, wants or has a use for this data can find a way relatively easily to receive those messages, whether it's in their EHR, it's some kind of population health system, or some other tool. And so you have these two different kind of formats that were designed for completely different purposes. And, our challenge kind of in this pilot on the technical side was reliably converting between the two and getting the data out in a, reasonable period of time so that the people who get it need it. And then also so the EMT agencies get data back from the hospitals through the Health Information Exchange, MyHINSS, statewide ADT service, so that they can track outcomes, effectiveness, et cetera, and, demonstrate the value of their work. Can you go to the next slide? So, right, I mean, this is kind of a breakdown between the two different formats, right? We have a much larger XML document in the NEMSIS format. It's, more of a quality, a document that's used for quality reporting and, analytics. Another kind of challenge, especially when you're thinking about data coming back to the EMT agencies, depending on their infrastructure and what other systems they have in place and what type of documentation system they're using. Patients can be organized by kind of specific calls or incidents rather than in a typical healthcare format or setting where you'd have like a medical record number and then different encounters. It could just be kind of more flat with just an encounter-based identification. So on the receiving end, there's a challenge with the patient matching reliably, especially given the circumstances under which a lot of the information is collected for receiving and reporting on the ADTs they receive back. But going back to sending the data, right, the big challenge is getting the NEMSIS data, getting an appropriate and useful subset of the data into an HL7 format, flagging it appropriately, as Sam talked about, for sensitivity, and then getting it out to a health information exchange, in our case, and then having it distributed reliably. This becomes kind of another event notification in an event ADT kind of event notification service. Next slide, please. So kind of this is the workflow I think we all kind of probably are used to in these types of projects. The EMS agency in this case, it's going to be completes the data, the documentation. The NEMSIS files are generated periodically on a regular basis. In this case, we receive those files, and we have a process in place to both pull the demographic information out of those NEMSIS files so that we can submit an active care relationship file, which for people not involved kind of are using MyHIN services as a, for lack of a better phrase, like a patient roster of, so this EMS agency is asking for ADTs or something for these patients. So we create that dynamically as we're getting the NEMSIS data and submit it. And then we also create the ADT messages and flag them appropriately through that process. From there, it just goes out to the health information exchange. And, as we bring this pilot live, it'll hit the MyHIN's patient matching active care relationship service and be routed appropriately to whichever providers and health systems have a relationship with that patient so that they're notified and can follow up appropriately. On the other loop back, now that we're submitting these active care relationship files for the EMS agencies, they can also receive admission and discharge information from the hospitals and other entities in the state so that they can start doing reporting, trending, et cetera, to see that, hey, if we're seeing someone, we're not having to transport them to the hospital, they're having this many, they tend to go to the hospital later or whatnot. Just, different reporting that they can do to demonstrate their value and perform follow-up and keep track of the work that they're doing. So it provides kind of a complete 360-degree kind of feedback loop on the work that they're doing. All right, the next slide, please. Yeah, I mean, and this is right why the ADT notifications back or going back to the EMS providers is important. As was mentioned earlier, it's difficult to know what happens to the patient afterwards. So this lets them know, like, we transported a patient to the hospital, then they were transferred somewhere, they just stayed in the ER, they came home, or we saw a patient, we didn't transfer them, but 24 hours later they were in the hospital anyway. This would provide that kind of linkage for them between their incidents and activity and future activity for that patient. A challenge, though, in this is making sure, right, the data that you get back. So in this case, we're getting back raw HL7 data from the state HIE. It's put into a format that can be usable by the EMS agencies in whatever kind of reporting infrastructure they have, or the reporting's done in a way that they can use. And as I mentioned earlier, that if you have situations where the structure of the documentation system is based on encounter or incident instead of a unique medical record number for each individual person that's entered into the system. It's then, taking that hospital event and matching it back to, the incidents that that person had instead of, a one-to-one, MRN on the EMS side to MRN, an account at the hospital side. Next slide, please. Yeah, I mean, as with any kind of project, right, there's considerations and implementation lessons that we all learned. I think the biggest one, right, is that the NEMSIS files have a lot of data. It's when you're sending a notification to a provider, it's really talking through with the recipients, or at least a subset of the recipients, about what data is important for them to have, because you don't want to send this whole document that's too big and difficult to go through, or just translate a whole document into an HL7 message, or try to rather, and have them try to do something with it. It's finding that appropriate subset of data. I think, another one is doing a lot of testing, right? And anything that has to be protected additionally and isn't, flagged with some kind of binary flag, like, hey, protect this, record more than some other one because of the information in it. Instead, if you're in a situation where you have to look through the record and find indicators that should show that you should provide, an SPI flag for it in our case. Rigorously testing those and coming up with a set of rules is important, and balancing the need and the desire to be overprotective with information so you don't send something you shouldn't, while at the same time possibly, risking flagging too many messages and making the whole project unusable for people due to, it not being reliable enough. I think the other two kind of things that you want to look at is, I think, making all of your work off of using your base as a standardized file like the NEMSIS instead of anything peculiar or unique to the specific documentation system is important. Um, and, as you're going live, finding ways to make sure that you can monitor how effective this is, right? If you're sending this to an information exchange and then it's being sent elsewhere, like in our case, figuring out ways to match like how many messages that we're sending, in our case, if we're sending X messages a day to the information exchange, how many of those are going to somebody downstream? How many are failing and matching there? It's not just kind of matching on the way back on our end. So having some discrete, calculable kind of metrics to know if this is working right is important. Um, I think that the next thing that is vital, um, it is really I think the best way to put it is uh, making sure you do something like, I guess, building off of the point with, not tying yourself to one vendor, building something that can be replicable easily, because you're going to have a lot of situations where if this isn't done on a statewide basis, like we're trying to do in Michigan, to make this reliable, you need to have and useful for providers, you need to have at some point a critical mass of agencies sending data. So you need to have something that can be implemented easily by different parties. And that was something that we made as um, a design decision on our end, is to build something that can be replicable easily at a lightweight without a lot of dependencies or third-party tools or products by anyone else. That way the work can continue and get a critical mass, and then it can be, the whole idea of EMS data traveling through an HIE to providers can become a norm in the workflow instead of just an exception for certain kind of pilot agencies. Next slide, please. Um, right now, this is where we are at this point. We've done technical testing end to end. Everything is working fine. And we have our initial pilot, as it says here, emergent health partners, and we're just planning the final, non-technical steps to go live with MyHIN for this pilot agency. And I think that that's really it. In our case, kind of bring it back. We also built and documented this so that it can be replicable later on by other parties, not just ourselves. So that's part of kind of our work product as well. But we hope soon to be bringing this live and sending this data to the statewide health information exchange, and then monitoring how it's working for providers, and hopefully adding more on soon. I think that is my last slide, and it's Q&A at this point.
No, thank you so much, Ed, and thank you so much to all of our presenters. So as Ed mentioned, we are transitioning now into the Q&A portion of today's webinar. We've already received, I think, several questions that have been responded to by some of our panelists. I don't know if we want to kind of go over those. Are some other questions. I think some of them may relate back to some of the things that we've already answered, but one of the questions we have is, if you're an organization just starting to think about kind of specially protected information, what is kind of the low-hanging fruit? Where do you suggest that they start in that process?
Yeah, so I can talk first, and I don't know if Emily has some perspective from the EMS provider and agency perspective, but I think it's important to understand who is going to be accessing your data, who's going to be looking at it, and why. I think you really want to make sure that you're not sharing data just for the purpose of data sharing. I think that's something that we see sometimes in this healthcare interoperability, data interoperability space, is that people are really interested in interoperability just for the sake of interoperability. And so making sure that you have a clear idea of who will be receiving your data and why, so that you can develop or implement some of the flagging rules that we've created, we've outlined in this framework, and use them properly.
I think I would add from, I mean, this is biased perspective, right? From the state, because we're going to try to do the repository into MyHIN, is to make sure that you know how to look at your data and how it's flowing into the repository in advance. So like you're ready for when this comes. So what are you sending? Is what you're sending accurate? Is what we have, does it match what you're sending? Are you having a bunch of failures? How are you looking in relation to the schematron to make sure that things are really, kind of set up and ready so that when we do get to the point in time, because I'm pretty stubborn, convinced that we're going to do it, when we do get to that integration point, that you'll know that you're ready and your transmissions are going well now. So you know that when we get to the point that we're sending and receiving, you'll be getting that information back. Sorry, go ahead, Sam.
Yeah, I just want to, Eric, I'm so glad that you brought up this first piece, because I know when we talk about EMS data, this is usually, I think, the big sort of like bottom line, underlying exclamation point piece about the value of EMS data, but we've sort of glossed over it a little bit, I think, at the beginning of this presentation. Many times an EMS encounter with a patient is the only encounter with a patient. Some of the data that we have looked at shows around 30% of EMS encounters do not result in a transport to a hospital. And so, the EMS clinicians are capturing data about a patient encounter that, yes, goes up to the state and goes to NEMSIS, the national level, and it's great data for us to have, but it's not going to the primary care physician. It's not going to anyone else on the patient's care team. And for patients that have chronic conditions or really serious medical concerns, it's important for providers on their care team to know about that visit. So I'm really glad that you brought that up.
Yeah, and I think to answer your question, the answer is yes. We have been very clear with this particular project of like, this is not going to be just a send. Like, this is not we're going to turn on, the flow of EMS data and everybody else gets to have it and EMS doesn't get to have it back. This is like I said, I'm pretty passionate about this particular work. And I think that also leads Eric to the point of like, you should be talking to your vendors to make sure that they're ready to receive also. Because, it's not that your clinicians are going to be logging into the repository to look at stuff during patient care encounters. So like, how do we make sure it gets back all the way to those people who are actually taking care of the patient? So yeah, it's we have been very clear on that it is a deal breaker for this project if it is not a send and receive, because we know the value of our data, so to speak. And I just wanted to touch real quick on what Dr. Kramer had put in the chat, and we kind of talked about, have we talked to other states? I have my nickname when I was a kid was Plan B. So I already have, like, if my first plan doesn't work, I already have like 17 other plans in place for like, what is, like, if I can't get everything in the first try, can I do this or also this or also this? So we have a whole bunch of like dominoes in a row so that we're going to get something out of this. But one of the lessons learned when we talked to Maine specifically was Maine's HIE refused to do matching without a matching MRN. And that was, in essence, made it so like Maine's EMS clinicians aren't using it because nothing is matching. Because getting the medical record number into the EMS NEMSIS record translated into the HIE has been like a really large stumbling block for them. So even though the data is flowing in, it's not matching and coming back out. So like, these are the conversations we're having right now to try to make sure that we don't end up in the same situation where we invest in it and then we don't end up having the positive outcome at the end of it.
So Emily, I mean, just to onto that, I think there's a lot of comments coming in about this being kind of in theory a great approach, but it requires a lot of other kind of participants and partners in the room because workflows are different. They have to operationalize things. What is maybe this is for all the panelists. What's the one thing, because we know this is about to go live, right? We've done some testing on this. And what is maybe the one thing that these stakeholder groups can do to be prepared over the next year to receive this information and be able to leverage it appropriately?
I'm going to kind of go back to what I said in a couple of minutes ago about making sure that your data is flowing consistently, and it's flowing in as real time as they can possibly make it. That's one of the things we see some people still batching records. Batching records obviously delays the ability for you to, get your information in a timely fashion. And making sure that you're able to log into the repository, and then talking to their individualized vendors and making sure that they can also receive. So we'll set up kind of, I think phase one will be here is this connection between the two big buckets, so to speak, so people can log into our repository and look at outcome data. Then phase two is like, how do we get it back into the agency's hands expressly? So like, then we can send back, and not all documentation vendors are used to receiving. They're really only used to sending. So just there are some that are kind of already more prepared than others, but I just want to make sure I put that out there as like one of the things that you have to start talking to your vendors about. And to Dr. Kramer in the UUID, have we talked about UUID? Yes, but it is not, because it's encounter-based and not patient-based, it's created a pretty big, I would say, barrier to that. I don't know if anybody else has more to add.
I just want to add a little bit on the, how to get people ready to use this data. I think Ernest put a good point in the chat, really, that, this can present a workflow capacity problem for receivers who, may be receiving ADTs, but just don't have the capacity to interact or address the information that's coming in already. And so I think, there are a few ways to go about this. I think what we are interested in is identifying pilot organizations who are ready to use this data to receive it and operationalize it, and work with them to really evaluate how this is working, and see how they're using it for specific patient use cases. I really think that that's key for this. For example, we've talked to health systems who are interested in doing this work um, for example, complex case management patients. So they already have a complex case management workflow set up on the hospital side, on the provider side, and they maybe have a specific patient population at a specific clinic that they really want to be focusing on. And to be able to narrow it down to a particular use case and then evaluate the impact of understanding and learning about EMS encounters for patients, especially when they're not transported to a hospital. I think that's really where this is going to start to build into a more normal and standard workflow for receivers.
And I think in a previous question response, you mentioned the UUID. Can you kind of talk to the audience for us lay people about what that is and how that relates to the work that we're doing?
So the UUID is a NEMSIS element that generates inside the documentation tool that's created that like is specific and individualized, but it isn't necessarily tied to a single patient. So it's not a unique patient identifier, it's an incident identifier. So you can talk about a UUID in reference to this particular, I'm going to say document, this particular record. But it doesn't, you can't tie that UUID to, this particular patient always, because that patient might have, if they've seen an EMS clinician 15 times, they have 15 individual UUIDs for each one of those incidents where they encountered EMS. So that's kind of an interesting thing. And then for the hospital answer, and I'm not going to say who, but the My Stroke program at MDHHS is actually working with a specific health system on the other side of our project. They have some rural health transformation dollars to help operationalize it on the hospital end too. So we're hoping that, we can kind of use them as a pilot project in order to like make sure that we have kind of the plan moving forward for how we can implement it the best way for the simplest implementation for hospitals and health systems. We have one benefit of like there is one major vendor in the space and several smaller vendors, but a lot of hospitals will all implement very similarly because they all utilize the same vendor. So that we are keeping an eye on the hospital side too. We haven't forgotten about it in this big project, mostly because there are several areas of MDHHS that are kind of all working in tandem on this, because when we wrote for the grant, there were actually a few areas of MDHHS that all asked for the same thing. It wasn't only us who asked for it. So like in separate areas, everybody asked for it. So that's, I think, why it was so easily slid into the application. So.
And I'm just realizing I am not off mute. I am so sorry, everyone. So we're getting a couple questions around rural health, that being kind of brought up by several members of the panel. So several of you touched on rural healthcare and the transformation program. Where do you think EMS data integration and this type of work could be leveraged through the program to improve care in rural communities?
I feel like I'm talking a lot, so I was trying to wait to see if anybody else really wanted to do it. So I'm going to talk, I think there's kind of like three buckets here. So there's like from the EMS side, which is the stuff that like our office controls. So I touched lightly on it earlier, but we have done, even since I came into the office, a lot of work to, modernize and utilize EMS data and, evidence-based practices to really change the protocols and make them be as close to what like a clinical person in a hospital would get. The problem is we don't see, other than like more people are getting to the hospital or more people are not getting to the hospital. It doesn't really say like how many people are walking out of the hospital, how many people when they walk out of the hospital are, the same as they were when they left. Dr. Kramer's here, so I'll say like for the concept of like pre-hospital blood. This is a big initiative and rural communities really need access to that resource, but it's really expensive and it's hard to get to them, etc. And like trying to get the all the way through. So like by giving pre-hospital blood on the scene as opposed to waiting to the hospital, they're giving 4 units less in the hospital, or the patient staying 3 weeks less in the hospital. Like those particular outcome measures can drive clinical care and improve patient outcomes, for everybody. I would say that's one piece. From the perspective of like primary care, I have to say, like, I have a bias in this space. My husband, works in primary care. He, like, we have talked about this a lot. Like, the primary care practices are like, they want this so bad because they can provide more intervention if they know this stuff is happening, but they just don't even know. It's like a whole other planet to them. EMS and how EMS works, it's a whole other planet. So like patients theoretically can be just generally less chronically sick because their primary care practices can find out about this situation before it gets to the point that they get to the hospital. And then I'm going to use the hospital perspective of, they can help say, EMS, if you did these 4 things differently, your patients would spend less time here. Or if you did these 4 things, they would never have to come here and they could, stay at home. So I think the possibilities are endless. I mean, I'm very glass half full on this particular data connection, but I think the possibilities are endless for how rural communities and rural patients could have their lives improved by this data connection happening.
One thing that I just want to add really quickly, I know we're running out of time, to complement what Emily just said is, something that our team at Chart is also really interested in and focused on is how changes to the way that healthcare is funded at the federal level and the state level are impacting how people are accessing healthcare. I think that we've noticed, probably a lot of you all have noticed, in rural communities in the state of Michigan, closures of certain hospital departments, closures of hospitals and mergers that have maybe resulted in less access for folks. And so having a way to capture patient encounters in these areas where they might not have access to healthcare in the way that they used to, capturing these EMS encounters is going to be even more important.
No, thank you so much, group. And as we as Sam mentioned, we are coming up against the hour. As we wrap up today's webinar, I'd just like to thank our wonderful presenters and all of you for participating. If you weren't able to get your question out today, and if you'd like to perhaps continue the discussion, please feel free to reach out to our speakers directly using the contact information on the screen. With that, I will hand things over to my colleague Art Nicholas to close us out.
Thank you, Sharon. Art Nicholas, I'm the president-elect of the Michigan HIMSS chapter. This type of content and discussion is a great precursor to our fall conference, September 14th and 15th in Lansing. On the 14th, we'll have a morning session anchored by Chart on Social Care Sustainability Summit. In the afternoon, we're going to have tracks for both professional development as well as public policy. And then on the 15th, we're going to have quite a number of presentations building off of some of the things you heard today about interoperability, about cybersecurity, use of AI in healthcare, and a discussion about the Rural Health Transformation Program. So we definitely look forward if you get a chance. I'll also include the link for this registration in a follow-up email that you'll get. And in addition to joining us at the conference, there's several other ways you can stay engaged on the next slide with the Michigan HIMSS chapter. And again, I'll include these in a follow-on email you'll get. We have a LinkedIn page which you can follow. We have a website that has a lot of information about opportunities, future events, volunteering, etc. And you can also join if you're not currently a member of HIMSS. We have a link. You can join HIMSS as a global member. You can also join as a Michigan chapter member. We've got an email below. Feel free to reach out to us if you're interested in getting involved or if you have additional questions. Thanks again for joining us today. It was a very active, very engaged group that we had, which we appreciate. Finally, just giving you an understanding of a little more for those of you that may not be extremely familiar with HIMSS. who the organization is. As I think we mentioned earlier, the Michigan chapter is part of a global organization that is really focused on innovation, public policy, workforce development, research, and analytics to advise various stakeholders in the healthcare space. And I know we've run over by a minute, so thanks again for staying with us, and thanks to our presenters today.